Assalamu alaikum. The communication day. First scenario, Mr. Jack, 20 years old, awaiting to see you in the acute medical unit. He was admitted with short of breath for 2 days. He was discharged from emergency department for the same complaint, for which he had chest X-ray showed minimal pneumothorax that didn't warrant intercostal chest tube insertion at that time. Today, chest X-ray showed increased size of the pneumothorax. He is short of breath but vitally stable. Please talk to Jack, address his concern, and discuss the next steps with him. Ready, Dr. Mahmoud?
Yes, ready, Dr. Bassem.
Okay. Dr. Omar?
Yes, I'm here. Can you hear me?
Yeah.
Can you hear me
Yeah.
very well?
Yes, perfect.
Okay.
Okay, hello, good evening. I'm Dr. Mahmoud. Doctor is one of the doctor here. Let me confirm you are Mr. Jackie, 23 years old.
Yes, I'm Jack. Yeah. How are you, Dr. Mahmoud? Yeah.
I'm very good. Mr. Jack, we are here to discuss about your medical condition and also to update you about your condition. So before we start, could you tell me how much you know about your condition to be on the same page, please?
Well, I know that I came to the E&E 2 days ago, and they had an X-ray where they found a little bit of collection of air around my lung. The doctors at that time wasn't concerned, but to be honest, today I became more short of breath. So I rushed back, as they already told me if there's any further short of breath, you should come back. They did an X-ray, which I still didn't receive any update about it, to be honest.
I am very sorry for your suffering. But before we start, Mr. Jack, could you tell me, do you expect anything from our meeting today?
Not particularly. I'm just looking for a relief of my symptom. To be honest, I have plans to do, which is I'm stuck at home because of the shortness of breath, to be honest, for now 3 days.
Yes, Mr. Jack, I understand that the shortness of breath is very difficult for you. So let me explain to you the whole condition. As you mentioned, you came since 2 days to the hospital with difficulty of breathing, and we did the scan and it show you have a condition called pneumothorax. Are you aware about this condition?
Yeah, they explained it to me last time when I was here in the ED. This is the same, like air collection around the lung. Is that correct?
Yes. Do you want me to explain more, or you want me to proceed more in your condition?
No. I'm just trying to make sure that it is nothing new in my X-ray.
Okay, Mr. Jack. According to this scanning to the chest from previous 2 days, it was like a small pocket. It is called pneumothorax, and it can cured without any intervention, without any procedure, without any further workup in the hospital. So we discharge you from the hospital and monitoring you. When you came today to the hospital, we did also another scanning to your chest, to your lung, and it revealed that you have this pocket was enlarged more than the last one. What do you think about that, Mr. Jack?
I knew it. Yeah, I had the same feeling about that. It might be progressing. So what we can do now for it, Dr. Mahmoud?
Okay, Mr. Jack. At this moment, we have to admit you in the hospital. That is the first thing. And then we'll make a group of specialists, like
Really?
chest. Yes, Mr. Jack, because let me explain to you more about pneumothorax. This is a serious condition. If not treated, it will harm your health. This collection in the lining layer of your lung, let me draw to you. That is your lung, and this is surround called pleura. It is a layer of the lung. When there is air inside this layers, it can compress the lung, and it can cause difficulty of breathing. It can cause harm to your lung. Furthermore, it can compress in the heart, cause a condition called tension pneumothorax. It is a serious condition and can cause your blood sugar, your blood pressure going low, and it can cause collapse, and it is life-threatening condition. So you have to be admitted in the hospital.
Yeah, so Dr.
Yes. Yes,
Yeah,
Mr.
sorry,
Jack.
Dr. Mahmoud. So, in this admission, what will happen next? Like,
Yes.
are they
Okay.
going? What else they are going to do?
Yes, Mr. Jack, I appreciate your concern, and I understand this will be difficult for you. But we will admit you and make a group of doctors, specialists like chest doctor. He will monitor you. There are some option. First of all, we can monitor you, keeping you on oxygen. And if this bucket enlarged more, then we have to do a procedure called video assisted thoracoscope. Do you have any idea about that, Mr. Jack?
No, to be honest, no.
Okay, Mr. Jack. Okay, that is my draw to.
No, can you hear me? Can you hear me, Dr. Mahmoud? Can you hear me?
Yes, Mr. Jack. I hear you clearly.
Oh, okay.
Okay, let me draw to you. This procedure is done to evacuate the layers of the lung from air. That is the lung, and we between the chest bones, we introduce a special type of needle between the chest bones, and it then connected to like a bag. Inside this bag is water to evacuate the air from your lung. This condition will be done under expert team. Will give you a painkiller to keep you comfortable, to keep you without any pain. It will clean this area. It will be by image guided. How do you how does it sound with you?
So is it the like a tube insertion to my chest? Because last time the doctors did say that I wasn't they didn't consider me for any tube insertion into my chest. Is is it the same as the tube insertion, or is it different? Is it does it sound like surgery or something?
Yes, it will be a small surgery. It is the same, yes, like you said. If you accept to do this procedure, you have to sign a consent in which all information is mentioned.
2 minutes left.
But to be there is this procedure, like any procedure, has a bad effect, like maybe injury to adjacent body part, maybe some bleeding, maybe some bug infection. But this bad effect is rare with good handed. We will monitor you after this procedure. We will keep our eyes on you. How does it sound with you, Mr. Jack?
Dr. Mahmoud, if you don't mind, so if I don't know if it's the first time I do have this, I've never experienced this into my life. Shall we jump to the surgery straightforward, or just a simple tube? Or because to be honest, I do prefer not to have a tube or anything. Is there any other option other than surgery or tube?
It will be, I appreciate your concern, Mr. Jack, but it will be the decision of chest doctor. He will monitor you first. He will monitor you, and if need this procedure, we will discuss with you another option. But let me ask you, Mr. Jack, what do you do for a living?
I am a freelancer, to be honest. I work from home most of the time, but I was planning to travel next week to the US for some work there. Now I think my plans are ruined. I don't think that I will be able to fly soon.
I'm really sorry to tell you that, Mr. Jack, you will unable to fly at least 6 weeks, and then after that we will assess you. I'm sorry to tell you that you are unable to fly. Do you have any hobbies like any diving or scuba diving or hiking?
No.
Do you smoke?
No. It is freezing cold nowadays. So, yes.
Okay. Smoking is totally.
Yeah.
It is advisable to stop smoking because it had a risk on your condition.
Yeah, I will stop. Yeah.
Okay. Thank you. Do you have any concern, Mr. Jack?
Yeah, I will stop. Yeah.
Okay.
No. Thank you very much.
Thank you.
Okay.
Thank you.
Thank you.
Okay. Thank you, Dr. Mahmoud. I added some text because there is some lagging in the connection between you and Dr. Omar.
I was wondering
so
if
you can
it's
comment
because
now?
of my side. Is it because of my? Is it because of?
Yeah, I think from your side.
I'm really
yes.
sorry.
Yeah, I think
I'm
from your
really
side.
sorry for that. Yes.
No worries. It's okay. And now we can. You can comment, or I will comment because you're driving.
No, I'm not driving. I'm sad because it's freezing outside. It's very freezing outside the car, so I'm sat inside.
Okay, so you can comment the skills in the chat box. You can comment now, please.
Yeah.
Okay, go ahead.
So for clinical, for the first skill, Dr. Mahmoud, you have a very, mashallah, you have a very good good knowledge. But you had a good intro. But it could be a little bit more better. Like you've used well the scenario in your favor to start the conversation with the patient, but then you repeated a robotic like statements. I appreciate it.
Sorry, Dr. Omar.
Hello.
Yes, we hear you, Dr. Omar.
Oh, so I was sharing in the very beginning. I wasn't concerned about certain things. I was wanting to proceed more with scenario, but you kept repeating. I appreciate your concern. I will try. So while the fact that the patient didn't have any concern, the main concern in this sense was about the shortness of breath. What's going to happen next? So yes, you've said it well in the beginning. I'll admit you will monitor your will put you on oxygen, monitor you with serial X-ray or something like that. You've said, and then your options can be three things. Mainly, intercostal drain. If he doesn't want to have an intercostal drain, which he didn't argue about, he was opting for it. He can have ambulatory device if it depends on the risk factor. He's young, he's vitally stable, he is symptomatic, but he doesn't have any features or sign of any adverse signs like above 50, smoker, long life smoker, bilateral hemothorax, bilateral hemopneumothorax, or vitally unstable. Those would warrant immediate intercostal tube. But he is symptomatic. If he is symptomatic, we need to assess, we need to do a CT chest, another form of imaging, and then based on that, we can discuss the options. There is a rapid symptomatic relief option, which will be putting a drain in your chest, or there is an ambulatory device option, which if the patient favors the mobility instead of staying at hospital, I think this should have been addressed this way. This is the first time he had this, so I don't think he needs VATS at this time, or blurodiesis. I don't know, Dr. Basim can agree with me or have a further addition about this particular part. But I felt that even though my colleague who had this scenario didn't discuss VATS or anything, he just offered the same options that I was discussing, and he got a full mark onto in this scenario. It came last died. So he, if it's recurrent, then yes, VATS can be discussed. Did you get my point, Dr. Mahmoud?
Yes, that is my hesitating, that it is recurrent. So I think recurrent and that pneumothorax size increased. So I think recurrent.
No, it wasn't recurrent. So he was admitted. Yeah, he was admitted 2 days ago. So it is basically the same pneumothorax. He didn't have. It wasn't relieved and then came back, but it was actually progressing in size. So pay attention to the wording that they use in the scenario. And you can simply ask the patient, is it the first time you have this or not, if you are in doubt. It's not a history taking.
Yes, Dr. Omar. Yes. So it is the same. Minimal pneumothorax and this, increase.
You had this.
But yeah, what is the ambulatory device for pneumothorax?
Device. So do you have the new algorithm of pneumothorax?
Yes.
The new changes.
No. We had it in the 2023. We had shared it.
So if the patient is symptomatic,
we had shared it in the group. Yeah, continue. Then I will comment. Continue.
Yes. So when I get home, I will share it. Yeah. Can you hear me?
Yes, Dr. Omar, we hear you.
Hello.
Yes, we hear you, Dr. Omar, but there is some lag.
Yeah, I'm sorry. So according to the algorithm, if the patient is symptomatic, then next, does he have any signs of any adverse sign, which is smoker above 50, or vitally unstable, bilateral hemopneumo or bilateral pneumothorax, or traumatic, basically pneumothorax. If any of this is present, even though anyone to drain, so you need a CT because X-ray doesn't show the posterior aspect of the pleura. So you need to do a CT for appropriate size, measuring the size. Then then according to the size, if it's safe to drain, then you can drain. You provide the patient if the patient is symptomatic only, vitally stable, everything is going well. They didn't mention in the scenario, and in his scenario, they didn't mention any size. Okay, so
yes.
If it's not mentioned, don't assume. So based on that, you've said a very, very brilliant thing, which is we will monitor you. So likely he will have a serial X-rays or even repeat CT to progress. If needed, you will have a tube insertion. If not, then the ambulatory device, which you're asking about, it's not readily available, but it would sound good if you said it to the patient to provide him an option, because he might. It's based on the patient option. To be honest, he's just symptomatic, but he's vitally stable, doesn't have any adverse sign. So the management depends on the patient option. One patient would prioritize mobility over rapid symptomatic relief. If he prioritizes mobility over rapid symptomatic relief, then you can go basically for ambulatory device, which is a device you will place it as an inpatient, then discharge him next day, and he can come back for serial X-ray every 2 days till the resolution of the pneumothorax. Or no, I want rapid symptomatic relief. Then it's a drain. So we'll put a drain in if needed, but before that, I think it will be decided if they will do a needle decompression before the drain, or they jump directly through the drain. I will leave this to the discretion of the chest doctors. That's it. He will say, okay, so whatever you would like, then we can proceed with that. He will tell you, oh, but I need to travel. Even though if you are given the ambulatory device, you will not be able to travel. After resolution of pneumothorax, I think the time is 1 week after complete resolution, not 6 weeks. 6 weeks may be after the surgery. Dr. Bassem can correct me on this if I'm not.
No, 6 weeks for the pilot. 6 weeks for the pilot.
For the pilot, okay?
Yes, yes.
6 weeks. So
1
it's
week
1
for
week.
the passenger.
It's 1 week
for the passenger.
For
yes.
the passenger.
Yeah. You got it, Dr.
So
Mahmoud.
for clinical
Yes,
communication.
Dr. Bassem.
Yeah.
Yeah,
Go
for
ahead,
clinical
Dr. Omar.
communication domain, I think I will give satisfactory. Clinical judgment, I would give borderline, because concerns, you've managed a concern. Welfare, it was maintained. So satisfactory, borderline, satisfactory.
Perfect. Yes, I agree with the same. I will mention why he could be minus in the clinical judgment. Because you mentioned
VATS.
the VATS, yes. I agree to mention VATS, but not as a first option. When you said we will do a procedure for you, you mentioned the VATS as a first procedure, which is not the case here. VATS for recurrent pneumothorax, or if the patient, you want to understand why this patient is having pneumothorax despite of treatment and it's not resolved yet. VATS is not as the first option for first pneumothorax in a patient.
Yes, believe me, Dr. Bassem, in my mind, I was being chest tube.
Okay. Because
Really?
you explained the chest tube after that. You didn't talk about VATS, but you mentioned VATS. I don't know why.
When he came in my mind, that chest tube under image guide, so my نطقتها VATS مش عارف. I don't know why.
It happened. But
really, I mean.
Take care. Yes.
And this happens in the exam. And this
yes. Really, I mean
happens in the exam.
In my mind,
from the stress, you can correct yourself.
Yes.
Because to be honest, Dr. Mahmoud, I asked you. They told me last time I will be doing a tube, but what you are explaining sounds like surgery. Is that what you are meant? But you didn't clarify after I asked.
It's okay. It's not that much harm, because you talk about other option, which is the chest tube. But suppose to start with chest tube, since the patient is symptomatic now, he is in short of breath now. So you are judging in his condition right now. Yet yesterday he was possibly for chest tube and he improved. But again, he came back with a worsening short of breath. So any symptomatic pneumothorax patient should be managed surgically, of course. So what you have to mention here, the chest tube. Or as Dr. Omar said, ambulatory device. By the way, Dr. Omar, ambulatory device is not a big tube, it's big tail. Big tail will be inserted and connected to a device which can be carried, not like the chest tube and Blurovac. So the patient can be ambulated with this ambulatory device.
Yes, and even here it's not widely available. It is available in some hospitals only. But since you are in the exam, you are in liberty of discussing all options because it's in the exam setting.
Yes, exactly. So whenever you are talking about, you can talk about it, but you have to mention there is surgery to be done for you. We have to drain this air by certain methods. One of them, chest tube. Then you can draw the chest tube, how it will be inserted, the procedure, the pre and during and after, preparation, admission, which is good step,
because
we will admit you to the hospital. Then,
yeah, I'm sorry.
yes, don't worry. What you want to say?
I was saying to give a logical, like coherent options, because likely they will, the surrogate do have a concern based on what you are saying. So if you started from that, it would be a little bit odd. But if you started from chest tube, and then he might be telling you, okay, is there any other option? You can verbalize the ambulatory device, but then he will be having a concern. Okay, right now, if it happened again, we do have, we can, we have a procedure called VATS, and this is to minimize the recurrence. And then his line of concern, expected concerns, are finished. And then what is remaining would be a travel or a risk factor like smoking, which he needs to stop.
Yes, exactly.
Okay.
The good thing also here for the clinical communication, you address the all risk like smoking, like diving, the hobbies, hiking, and the flying. You are lucky to be mentioned by him. But suppose, I think you can cover it. You will remember it. You cannot forget the flying in pneumothorax patient. But
Yes.
always remember the timing. It's 1 week for passenger, 6 weeks for the pilot. Okay? After resolution of the pneumothorax, and of course, the X-ray confirmed that there is no pneumothorax. Okay? So you can get 14 out of 16, and please don't repeat what the patient knew already. He told you that I know that I had pneumothorax. Then you said, I will tell you. You admitted with something called pneumothorax. He knows all this.
But I wanted to tell Jack that the complication of
complication, you can proceed with the complication directly. I will talk about the complication of your condition if you don't mind. Yes, doctor, please let me know. No need to mention what he has. Okay? Unless he told you, please, doctor, explain for me what is the pneumothorax. This is the first time. No one explained for me this complication or this condition. I want to know more about it. Any of these sentences or phrases mentioned by the patient, you have to address. Otherwise, no need to explain or to talk about it. Clear?
So one more thing, he didn't praise the patient when he told him that I came back because I was safety netted to come back to the A&E. This would sound more communicative.
If he come back,
when I told him I came back, I was in A&E 2 days ago, and I had the collection, but then I came back because I was told to come back if there is any symptom, if there is any worsening of shortness of breath.
You can use it, and always start by saying, how are you now? Do you feel good? Because this patient is feeling short of breath in the sentence. So you have to ask about his condition. How do you feel now? Do you need some oxygen? Do you need some painkiller? You have patient symptomatic, so you have to address this thing. Okay? Be careful about this. Okay.
Yes, Dr. Sami.
Dr. Omar, your scenario. Mr. Sami referred to the gastroenterology clinic by the GP due to symptoms of abdominal pain, intermittent rectal bleeding, and change in the bowel habits over the past few months. These symptoms raised concern about possible colorectal pathology, including colorectal cancer, and a colonoscopy was arranged. He attended today for his scheduled colonoscopy. However, the procedure couldn't be completed due to inadequate bowel preparation. As a result, his colonoscopy has been delayed, and alternative diagnostic option may need to be considered. Your task is to explain the reason for the delay in the colonoscopy due to poor bowel preparation. Discuss the importance of adequate bowel preparation for obtaining accurate and safe results. Address alternative diagnostic options that may be considered, such as CT colonography. 2 minutes, Dr. Omar, we can start.
So, sorry, Dr. Basim,
Yes.
the case of pneumothorax, last case, I will tell the patient we will monitor you, keep you in the
Yes.
hospital. If you need a tube, يعني like option.
Mostly this patient will need a tube because
Yes.
he came back with increased size, and this is the most important, he's symptomatic right now.
Yes.
If you see the algorithm for pneumothorax guidelines, what they mention, symptomatic patient. This is the first thing you have to have it. The patient symptomatic and the criteria or risk criteria for pneumothorax. Above 50, bilateral hemopneumo or tension pneumothorax, all of them as add-on. But the most important and essential part in the indication, patient symptomatic. So
and so shortness of breath now is symptomatic.
Of course, patient came with short of breath. Yes. Okay.
So okay, Dr. Basim.
Yeah. Okay. So the surgery in the top of your options. If he said no, doctor, I don't want to be underwent this surgery, I want another option, you can tell him I will refer you to the doctor of the surgeon. He can decide or he can judge on your condition based on the X-ray, for example, based on the symptoms. But the first and top decision will be for intercostal chest tube or surgery or intervention. Okay.
Yes, Dr. Basim. Thank you.
Okay. Dr. Ida.
Hi, Dr. Basim. How are you?
Yes, I'm fine, alhamdulillah.
Shouldn't we discuss in this scenario the option of needle aspiration? Especially this patient primary pneumothorax, spontaneous pneumothorax.
Yeah, it's a good question. I will revise the guidelines because before the old one, there is, according to the size, if less than 2 centimeters, they can do the aspiration with needle. But it's not in the option
new
anymore.
Guidance. I'm sorry, Dr. Basim.
Removed already.
Yeah,
I remember removed.
But no, but the new guidance is still, it's the needle aspiration still there if the patient is symptomatic only with no adverse event. The adverse signs that it is patient above 50 and smoker, patient who is having bilateral hemopneumo or hemo vitally unstable or traumatic pneumothorax. If it's not there and the patient is symptomatic, the next question, is it safe to intervene? Like you need to have a CT chest. Then if it's safe, then what is the option? It is patient dependent. So if the patient does prioritize rapid symptomatic relief, then needle aspiration. If it's not improving on needle, then chest tube. If the patient prioritizes mobilization, then it's an ambulatory device. If the patient refused any surgical intervention at all, then he will be conservative. But if he's symptomatic and it's safe to intervene, and the patient wants rapid symptomatic relief, then yeah, it is intercostal drain. In past medicine, they broken down the new guidance in a single page that is very, very good. I will share it when I go back home. It is very good.
Yeah, good. Yes, I remember also. It's very simple, but it's like stepwise. If you have, then they draw an arrow, so you will go to this plan. If not, you go to the other plan. If not, you will go to the next plan, and so on. But the most important, as I said, if symptomatic patient and there is high risk criteria, as Dr. Omar mentioned, the age and the vital and tension and bilateral, all of them mandatory to interfere. You have to do
intercostal tube. Yeah.
Yes, exactly.
But this scenario,
but your question,
intercostal tube, even if asymptomatic, but he does have those adverse, like he's above 50 and smoker, and he is not having any symptoms, and there is pneumothorax, he will be always for chest drain.
Okay. Maybe Dr. Ala, for the size, if the size is minimal in the CT, what I can remember, there is CT in the option. You have to do CT to know the size. If the size is low or small, you can do aspiration with needle. But let's revise them.
Yeah.
Okay, let's revise them
Mhm.
to be more updated. It's good and nice to be updated today about these guidelines because you don't know what you have in your exam. You might have this scenario.
Because especially if they didn't give you the
Yes,
accurate management plan,
exactly. Yeah,
yeah, you have to put your judgment in that discussion.
exactly. But the most
Yeah.
important is to say we have to drain this air.
ICT, yeah, the most important.
To drain it, to drain the air. ICT,
Okay.
the first option, ambulatory device, one the option. Maybe if he refuses, we can do needle aspiration. Depends on the size, and you can say also after opinion from the surgery, to say if it's for drainage by needle or just a tube. So don't put it in your responsibility. Put it to the other. It's a group of doctors. It's not your decision. But the most important to drain this air because the air is the one responsible for your pain or short of breath. Okay. Dr. Tahani is asking, need admission or not? Yes, of course, need to be admitted. Once you decided to insert, patient should be admitted. Maybe if the patient asymptomatic or if he has small pneumothorax or he doesn't have the risk criteria, you can also refer to the group of doctors. Don't decide by yourself that you will be out or you will be discharged. Okay. And if the patient insists to go out or to be discharged, don't forget to follow the steps of DAMA. First of all, to convince, meeting, and DAMA, because there is responsibility, high risk responsibility if this patient's discharged against medical advice. This pneumothorax might increase in size, and as Dr. Mahmoud said, it might affect or harm his life. Okay. Dr. Omar, are you ready for the next scenario? Second scenario.
السلام عليكم
عليكم
دكتور
السلام
هيثم.
ورحمة الله وبركاته. Okay, Dr. Hida, yes.
هو الفكرة إن السيناريو فيه أكتر من نقطة مش واضحة يعني.
Okay.
هو vitally
If you
stable.
can ask in the English, Dr. Hida, please.
Okay.
Yeah.
As regarding of this scenario,
Yeah.
okay, just direct first option to treat ICT.
Yes, exactly.
Direct without size, young patient, vitally stable. So when discuss as mentioned in the scenario, discuss the next step with him.
Mm-hmm.
Should we discuss after ICT or before ICT the steps one by one?
As I said, the first option is ICT. Why we say ICT? Because it's written in the scenario, it doesn't warrant chest tube earlier, right? You can see it in the sentence. So suppose
Yes.
this patient was for ICT, but the patient was okay, then he came back with worsening. So the first option is ICT. The problem if the patient argued with you, doctor, is there another option? Doctor, is it something to be for long time? What I should do if I have planned to fly, and so on. Okay, so but the most important here to explain as a procedure the chest tube, the steps of chest tube or procedure before, during, and after. And you can draw, you can use the drawing technique, the pneumothorax, where is it exactly, the chest tube, where is it will be inserted, and so on. But the other option, as I said, if the patient argued with you, or if he asks you to insert smaller tube, or if he asks you, doctor, can I move, or I will be ambulated. So it will depend on the scenario. However, the most important here and the top of your responsibility here to explain the chest tube as a procedure. Clear, Dr. Hida?
Clear. Okay,
Yeah.
thank you.
Oh, most welcome. Okay. Any other question before moving to the next scenario? Dr. Omar, ready?
Yes.
Yeah. Here.
Okay, patient age Dr. Omar 50 years old.
50 years old. And we are in a gastroenterology clinic.
Yes, you are in the gastroenterology clinic. Yes, Dr. Omar.
Has the timer start? Okay.
Okay. Mhm.
Hi, hello. My name is Omar. I'm one of the doctors in the clinic today. Are you Mr. I'm sorry, can I confirm the name?
Yes, I am Sami, 50 years old.
Mr. Mahmoud.
Mahmoud, okay.
Mr. Sami.
Okay.
It's nice to see you in the clinic, Mr. Sami. I do understand that you are here to discuss a few things, and I can appreciate from the referral that you're supposed to have a procedure which didn't took place, actually.
No, doctor, I don't know. I came today for camera test, so I am waiting it for doing camera test.
Okay.
Mm-hmm.
So you are here to do a camera test.
Yes, doctor, I have been complained from
Sorry,
lose weight.
apology for my confusion.
No, doctor, no problem. I have been complained from lose weight and tummy pain and bleeding from back passage. And I came since 3 days to doctor. He told me that it is urgent to do camera test from back passage. So he gave me an structure, and I am adherent to this instruction. Yesterday I take only fluid, and I came today to do camera test, and I am waiting.
Okay. So for now, does the doctors told you why they are doing this camera test in the first place?
Yes, doctor, I'm afraid of having cancer, like my father. My father have cancer colon, so I afraid. He tell me that also he wanted to do this camera test to know what going exactly in my gut.
Yes. So it is a very important test. However, I'm afraid to tell you this today. I'm sorry to tell you that I don't think that the camera test is going to take place today.
Oh, why, doctor?
What I have been informed about that there is the preparation for in order for the camera test for the camera to pick good images hasn't been done appropriately. So, and in this scenario, if we are trying to rule out a sinister thing like cancer, we need to have a good view in order not to miss anything. So the safest is to not to proceed this time with the camera test, and to have, because it's very important, to be honest, to have a very good views in order to take some samples and not to miss anything.
Mm-hmm. Okay, doctor. So why not safe? I don't understand why not safe to do camera test, because the doctor tell me that it is important.
So,
and now you tell me that
it is important, but as important. It's what I'm trying to explain is that if the preparation wasn't very well, then this would affect the quality of the images where the camera itself will see. So the team wouldn't be able to see appropriately what's inside the colon. And if we are trying to rule out cancer, it is vital to have clear vision within inside the bowel, or your within inside the bowel, to confirm and to obtain samples or tissue samples if needed. So without good preparation, this result might not be accurate. So this is why I said it's safer not to proceed with it under inadequate vision.
Okay, doctor. What I keep adherent to the structure of the doctor. He tell me that give me a structure to well prepared to the camera test.
Okay.
So I think it is a mistake from the doctor. It is a mistake from your side, your team, because they give me wrong structure. I think that, and now I concerning of having cancer. So it will delay my diagnosis.
Well, what you said is very valid. However, I can't judge on what instruction that's been given because I need to, it's not written in front of me, the exact instructions. I will clarify it with you in a second. For the second concern about the cancer, we do have other options not to delay the diagnosis. And I will discuss it with you in a minute. So I don't think, with the knowledge that in front of me, to be honest, right now, I'm able to judge if there is any misinformation that's being given. So if you don't, I can check the information later on and get back to you about the preparation. But we still do have another option for to proceed with.
I am really feel upset, doctor. I think it is a mistake. So what is the plan now? You will lead me like that?
I'm sorry?
What is the plan? What is the plan?
So I appreciate that you are frustrated, your feeling of frustration. But I wanted to reassure that we are having another option, not to delay the diagnosis, since the medical team, as concerned as yourself about the cancer, and we want to rule this out. So the other option would be a form of imaging, where it's a CT scan, where we inject dye through your vein, which is a form of a material that would be picked up by the scan.
2 minutes left.
And to draw the outlining of the bowel itself, to see if there is any abnormality that raises suspicion. Then afterward, if there is any, we need to have a biopsy, which is a tissue sample.
So it is the same from camera test? This is scan?
No, it is not. This scan is not a camera test. It is a form of X-ray-like image. We call it CT scan. Have you ever heard about CT scan?
Yes, doctor. Yes, I know that. So it is the same. It is the same.
Yeah. So it is basically. No, I'm sorry.
Doctor, yeah. Okay, keep on. It is the same like camera test.
It is not as it's not camera that will be introduced into the bowel as the previous test, but it is, as if you meant, as same as diagnostic as the camera test.
Yes, doctor. I mean, it is the same efficacy.
Is that your question, Hassan?
Yes, it is. It is the same efficacy.
Okay.
Like camera test. And if it is the same efficacy, like a camera test, how your doctor not tell me I did this scan instead of camera test? Because he told me that camera test will have many bad effect, like tear and perforation. So it is a simple test. Why you didn't did it scan?
So from my knowledge, from my non-specialized knowledge, which I'm not a gastroenterology specialist, I think that it is not as same diagnostic ability as the colon cancer, as the colonoscopy, I'm sorry, which is the camera test, but it is one of the options that we can use right now because we don't want to delay the diagnosis if there is any cancer underlying. It is still reliable, but not the first option, because the first option would provide us an ability to take a sample at the same time. So if you can see that this test would require 2 steps, which is we will arrange for the imaging, and then if anything found, we need to do a camera test again.
So what about the preparation?
To take a sample.
Okay.
Okay.
So for the preparation, I
minute.
think 1 minute.
Yeah, 1 minute.
Oh.
No, it's time is up. It's 11 minutes 30 seconds now.
Yes.
So yeah,
I didn't
1
see
minute
that.
added. No worries. I know that you are looking to your phone, but I think now the time for comment, Dr.
Yes.
Mahmoud.
Yes. Dr.
Based
Omar.
on the skills.
Yes.
Yes, you did well. But I think in clinical communication, I think it's satisfactory. But in clinical judgment, I think you didn't tell me anything. Sorry, in clinical communication, borderline, Dr. Omar, because you should start about my knowledge, not يعني assume that I know that the procedure postponed. I came to do this camera test and it is postponed, so you have to tell me that camera test is postponed. So in communication, I think borderline, Dr. Omar. In clinical judgment, I think also borderline. In the welfare, I think also borderline. Because you didn't tell me anything about the preparation. You didn't tell me anything about what is the difference between the CT colonography and the colonoscope. So I think it's borderline, Dr. Omar. Sorry. So when it start, I think it start
For the welfare or the concern.
The concern, I tell you many concerns. First, I tell you it is a mistake. No, it is not a mistake. It is maybe not prepared that there is the colon is not ready for the colonoscope. Not a mistake. But also you should tell the patient we will ensure that.
I didn't confirm that it is a mistake.
Yes, you should confirm
I
it is
didn't say
not.
It's a mistake.
Yes, Dr. Omar. And also the task, when to look the task.
No, I didn't. Yeah.
Yes, the task was importance of adequate bowel preparation, and me need CT colonography. So I will start from the first. This came from exam. So when start, how much you know about your condition? I will tell you that yes, doctor, I have lose weight. I came to tummy pain, lose weight, bleeding back passage. So what is your expectation? Do you expect anything? I will tell you yes, I expect it is cancer, doctor. I will argue with you. No, I am sure it is cancer. It will affect the outcome. So you should, if we proceed in the scenario. So as the first, you tell me that I'm very sorry to hear that your camera test postponed. I will tell you why, doctor, it is postponed. Because it is there is inadequate preparation. So doctor, I keep in the preparation. The doctor give me an instruction like keeping in water yesterday. You tell the patient that I am sorry, your colon not prepared well. It is not a mistake from our side. Neither mistake from the patient. The colon not prepared. There is not prepared for the colonoscope. So we have to postpone. Why, doctor? Do this colonoscope and no problem. So not prepared, there is bad effect of not prepared colonoscope. First, you have to draw that is the colon, and there is the stool inside the colon. When we insert the camera test, we can't see clearly يعني which if there is any polyp or growth or anything, we can't see clearly. Added on that, it will take long time. It will be discomfort for you, and we may need to repeat the colonoscope again because we may not see clearly. So then I will tell you, okay, doctor, what is the plan now? So the plan, that is a clinical judgment. We will reschedule again to colonoscope. Okay, that's number one. Number two, we will assure that we will give you clear instruction about the diet, about the medication to clean the gut, which is laxative. Also about the timing of giving fluid, and everything will be clear. It will be clear in structure. Will be assured that it will be clear for you to be well prepared. And then there is another option. It is called the CT Colonography. What does that mean, doctor? CT Colonography, it is scanning with dye. This scan, we can see inside the colon. It will be non-invasive, not like camera test. It will be no tear. But there is a bad effect. The bad effect of that, if there is growth, we can't take tissue sample from the gut. And then we will do again camera test. But it is a detailed scan. We can see in details the gut. So it will be benefit for you till we rescheduled again the colonoscope. So and then I will tell you it will affect my outcome. No, it is unlikely to affect your outcome. We will reschedule you as soon as possible, and we will arrange the CT colonography. It will give a good picture of a good picture from the colon, from the gut, if he has any growth or not. If there is growth, okay, we can proceed to colonoscope. If no growth, okay, it may be non-cancerous growth called polyp, maybe infection, but we have to reschedule again in the colonoscope with well preparation. And then I will raise a complaint, doctor, because I think it is a mistake from your side. No, I don't think it is not a mistake, but if you want to complain, it's your right. I will guide you to the proper pathway to patient advice relation service. And then nothing.
Okay, thank you, Dr. Mahmoud. I agree about the skills judgment. I will say why, because Dr. Omar started to explain the alternative maybe at the minute number 7, which is the main task here, to reschedule the patient and to explain the alternative. There is some argument from the surrogate, but you have to start straight away to the task. What's mentioned as a task in the scenario, you have to start earlier and try to minimize the time of argument. Yes, he's saying there is a mistake, so you address it well. Okay, let me review the file or the record, and if there is any mistake, we can address that. We can investigate. However, for the meanwhile, we have another alternative option, which is the colonography, and we'll reschedule you, as Dr. Mahmoud said, for another camera scan in another day. Okay, doctor, so what you will do? Now, the steps. By the way, I share the photos. It's not a dye through the IV channel. it's carbon monoxide or carbon dioxide through the rectal tube. So they will inflate the bowel with the CO2, and the image will be more clear whenever they are inflated the bowel. So no dye at all will be used or dye through the IV or through the blood channel. Okay, Dr. Omar, because you said there is a dye will be injected. It's not CT angio or CT with IV contrast. It's a CT colonography. I think we explained it before, but now to be more clear, I share the photos. So it's not the dye or it's not a contrast. It's just inflation with carbon dioxide. The next thing about the preparation, there is some preparation before fiber diet to evacuate your bowel and to be ready for the CT as soon as possible. Is it effective? It helps to diagnose, but once you suspect and once we have a mass or abnormal growth, we can go up with the camera scan to have a snip. Okay, a snip from this tissue. So the clinical communication again, yeah, I think there's some delay in the task. And I think also because of the lag in the internet, there is some problem today about the connection. Maybe next session will be better. The clinical judgment also because you didn't explain the procedure well, and there is some mistakes in the explanation, the steps I mean, no dye as I said. The concern, yeah, I think not all concern get addressed. And for the welfare, because you didn't also tell him about the arrangement for the next schedule. So I think I agree also about these skills as borderline 8 out of 16. But again, the scenario maybe due because of the connection, because of the misunderstanding. I think also you started the scenario without reading the scenario well. There is something missed in the front and in the first second or first minute when you ask him, "Are you aware?" And he doesn't know or he didn't know anything about the preparation. He just came to know. Yeah, one more point. You said to him at the end, which is I think this is a big mistake. Initially, you said I am one of the doctors in the clinic, but once he asked you, doctor, is it alternative? Is it effective? You told him I am not the doctor with this specialty, the gut, I mean. And the scenario was written that you are the doctor in the gut or gastro clinic. So there is conflict between the task and the position. And now you are saying like I am not the one. You can say I will ask my senior, but don't say I am not the doctor to know more about this. Okay?
Yeah, 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 yes. But for the one more question regarding the error,
Yes.
you can't be confrontational if the patient says or the surrogate says that there is, I think there is an error. Well, you can't, and it's not written in front of you. Yes, I know that it's not an error because it's not written as an error. But I won't tell the patient or the surrogate that you don't know anything. No, it is not an error. But so I said, well, I don't have any information in front of me about the preparation or the advice, but we will check on that. I appreciate your frustration. So then, if he keeps insisting on error, on medical error, and wants to take to that direction, I would have advised about pulse, of course. But I offered the alternative straight based on the concern. Why I offered it like on the 7th minute, because he was now I'm concerned about the cancer. Yes, we want to rule it out, so there is an alternative. This is why I went to this direction.
Yeah. Okay. Let me answer the first part, which is yes, I did say that you confront him. You said, yeah, there is something which I'm not sure about it. We will see in the record and we will confirm it. If there is any mistake, we will investigate about it. If he asks to complain, you can say you have the right to complain, and we will investigate also to know more and to update you about this result of the investigation. The second point, why you started at minute number 7, I think if you can earlier address that there is a problem in the preparation and we didn't prepare you well, there is something missing. So immediately start to the alternative. For that, we have another option, which is alternative for you as in the best interest of your condition, as decided by our consultant, which is called CT colonography. Okay, yeah, he might argue with you, but I think the discussion went very lengthy from the start till the minute 7 about why what happened, why I should be prepared. Maybe also the delivering of this news, you went late, you didn't do it earlier. Once you ask him, do you know? So you suppose you are the one informing him, not he is the one knowing that. Maybe there is some misunderstanding, but it's okay. Again, we are learning from the lessons and from the scenarios, and from every session, you know what you have to do, what you have to avoid, what you have to straight away advise, what else you have to do as a recommendation. Okay, so just learn from the lesson, and next time will be better. Okay. I think also you are not in the environment
Yeah.
ready to be practicing today. All decision like there is lagging in the connection, but it's okay. If you manage it today, better tomorrow to be in the comfort area in your room, suitable one, and calm environment. Connection will be good, and I think the practice will be better than this. Okay. Any question, Dr. Omar?
Yeah.
Okay.
Yes.
Yeah, Dr. Hina.
No. Thank you, Dr. Bass. Thank
Okay,
you, Dr.
thank you.
Mahmoud, for this.
I share. No,
Thank you,
thank
Dr.
you.
Omar. Thank you. Thank you.
Okay. Dr. Ihda shared the same session about the CT colonography. Thank you, Dr. Ihda. Really, it's appreciated that you are looking for this session. As I said, we have discussed this and we mentioned the same. It was also mentioned that there is a contrast, and we corrected this information. It's not a contrast.
But I
It's
think, Dr. Basim, it's according to the center. I mean that in our hospital in Qasim, there is no air. CT colonography by dye. And also in Egypt, it will be with dye. But in other center like Pakistan, it was air.
so the name will be different. It will not be colonography or CT colonography. It could be CT.
Colonography.
Maybe something cholangio means cholangio for the bile duct.
Yes.
Maybe CT abdomen with contrast, but it will not be the same CT colonography. CT colonography is confined to the CO2 inflation. We discussed this in the previous session, as I think Dr.
I will.
Hida, yeah.
I will listen to it.
Okay, but it's not dye. It's CO2 or carbon dioxide inflation. Okay.
Okay.
Anyone has question or doubt?
Yes, Dr. Basim, in such
Yes.
case,
Can we
it
send the
consider.
same? Oh, I'm sorry.
Yeah, go ahead, Dr. Omar.
Yes,
I'm
Dr.
sorry. Can we send the same photos on the group?
Yeah,
Because I
I
think
will.
after the
I will.
session.
I will.
Yeah.
Yeah, no worries. Okay. Yes, Dr. Mahjou.
Yes, Dr. Basim. Yeah, yes, you are right. Colonography is with carbon dioxide, and the others we call CT with contrast,
Yes,
with or
exactly.
without contrast. But in this, Dr. Basim, I'm just asking because I'm not familiar so much with clinical communication cases.
Yeah.
Is it considered procedure, right? So,
Yes, procedure. Yes,
so do I
yes.
need to raise the consent or
Exactly.
something like that?
Yes, of course. There is a consent.
Yeah, in any procedure,
Yeah.
I should
Why?
raise a consent.
Why? Because any complication might happen.
Yeah. So no one, I mean, this scenario, no one mentioned any
Yes.
things
Yeah.
about
I agree about that. And
the consent.
one of the important things to mention here, to be mentioned, the preparation before, during, and
Yeah,
after.
yeah,
Because this patient, after inflation, he should be also monitored. Maybe CO2 will do an perforation or any complication might happen. So this patient should be monitored after. Don't
exactly.
forget. Yeah. So it's a consent form you have to mention. Okay. I think Dr. Omar, Dr. Mahmoud, mashallah, he remembered the consent in the first scenario, but next scenario or second scenario, Dr. Omar, he missed the consent form. Thank you, Dr. Mahjoub, for mentioning this. Any other comment, Dr. Mahjoub?
Thank you, Dr. Basim. Thank you very much. Thank you, Dr. Omar.
Okay. Any other question from others, other doctors? Any comment? Any suggestion?
Thank you, Dr. Mahmoud.
Clear for all, both scenarios? Any question before ending the session? Okay, so time to thank Dr. Omar, Dr. Mahmoud. See you tomorrow, inshallah, with the short clinical day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله وبركاته.